Hi, my name is Braden Gibson, and this is my case study that I did this past semester. So getting started, the patient that I chose, this was their chief complaint. So the patient's chief complaint was neurological disorders. The patient had had a fall and was admitted to the hospital with general weakness. After being admitted to the hospital, it was suspected that this patient had suffered a stroke, and an MRI did confirm that they did have a right cerebellar infarct resulting in left-sided weakness. So the diagnosis that physical therapy received was that the patient did in fact have a right cerebral stroke with left-sided weakness, and to follow stroke rehab protocol. So the patient presented with weakness and balance deficits, and they were previously independent with their mobility and gait prior to admission. So the disease process, this patient presented to rehab with a right cerebellar stroke, which resulted in left-sided weakness. So this type of stroke is less common, but it occurs when one of the blood vessels that supplies the cerebellum is blocked or bleeding, which causes interruption to all or part of the cerebellum. And symptoms include left-sided weakness, fatigue, speech and memory disorders, nausea, dizziness, and balance disturbances. So this particular patient, balance was a big issue that they had. So their past medical history, this particular patient had a medical history of CHF, COVID, hypertension, and type 2 diabetes. So the physical therapy evaluation. So keep in mind this was at inpatient rehab, so you'll see that a lot of the tests that were performed is focused a lot on functional mobility. So for manual muscle testing, the right side was focusing primarily on the lower extremities was within normal limits. The left lower extremity obviously being the side that was impaired. So left hip flexion was graded at a 3 minus, left knee flexion and extension was graded at a 4. Left ankle dorsiflexion was 3 minus, left ankle plantar flexion was 3 plus, left ankle eversion and inversion were both 3 plus as well. So not terrible, but definitely a lot of weakness, which contributed to a lot of this patient's balance issues. So physical findings, hypotonicity noted in the left lower extremity, and the patient did have impaired sensation in the left extremity, specifically with light touch and deep pressure. So functional mobility. The patient at time of evaluation was max assist to roll left and right, as well as max assist for sit to supine, supine to sitting at edge of bed was all max assist. They were also dependent in their sit to stand. They were max assist with their chair transfers. They were dependent with their wheelchair management, so they were not really doing all that great. And at the time of eval, they did not attempt any gait due to the balance disturbances. So a lot of room to improve. So the long-term goals, the patient specifically stated that they wanted to get better and they wanted to walk by myself again. So as far as physical therapy goes, we wanted to be able to get this patient to be able to, the SU/CU stands for setup or cleanup. So basically independent with rolling left to right. They wanted the sit to supine to be at least contact guard, sit to stand contact guard, chair transfer. And when I say chair transfer, that's just transferring in and out of a chair that has bilateral supports for the patient to be able to push up. They wanted to be men assist with car transfers. They wanted to be able to walk at least 50 feet with contact guard, walk 10 feet on uneven surfaces with men assist. So uneven surfaces is just a wheelchair ramp. Be able to walk 4 steps with max assist. Be able to pick up an object with men assist. They wanted to be able to wheel 150 feet with supervision with their wheelchair, and they wanted the patient and family to be independent with the home exercise program. So the short-term goals, and this is what we primarily focused on with therapy, was our bed mobility, getting to where we could get to be min assist with bed mobility, min assist with our stand pivot transfers, be able to walk at least 50 feet with contact guard, and at least wheel 50 feet with min assist with a wheelchair. All right, so the treatment plan. So here at this particular clinic, the plan was kind of, I don't want to say vague, but it left a lot open for the PTA to kind of decide what types of exercises were performed. So you'll see that some of these plans are just kind of broad. So, but mainly focusing on balance training, ADL training, bed mobility training, caregiver training, community work integration, focused breathing exercises, gait training, group training, heat and ice PRN. This patient really didn't have a whole lot of pain, so we never really did a lot of heat or ice. A lot of neuro re-education, bilateral lower extremity therex, posture training, stair training, stretching, transfer training, and wheelchair management. This was all to be done 3 hours a day, 5 times a week for 3 weeks. So you'll see in parentheses it says an hour and a half for PT. This is an inpatient rehab where you're trying to split those 3 hours between physical therapy, occupational therapy, and speech therapy. So that's why we try to get at least an hour and a half a day with physical therapy. And the assistive devices that we wanted to use was a quad cane, of course a wheelchair, and this particular patient had quite a bit of left flexure tone in their upper extremity. So a left wrist extension splint to try and straighten out that wrist was also something that we worked with as well. So other tests that were performed. So what they ordered, obviously an MRI and a CT scan to see that this patient did in fact have a stroke. They also had a TEE test, which is basically just a heart function test. So again, the MRI and the CT scan showed that this patient did in fact have a stroke, and then the TEE test showed that the heart was functioning well enough for therapy. Alright, so the medications, I can't even pronounce half of these, so you can kind of look through these. You'll see that a lot of these there's 2 main things that this patient was being prescribed to treat, which is high blood pressure and diabetic related disorders. You can see here at the bottom they also had some laxatives ordered. So basically some big things to just watch out for medications like this is going to be dizziness and nausea, as well as just general weakness. So I was involved in the treatment of this patient pretty much from start to finish. I worked with this patient pretty much 3 days after they were admitted to rehab, and I was directly involved with their daily treatment as well, as well as progressing them through their plan of care and modifying exercises to better accommodate the patient. I would also update the supervising physical therapist about every 2 to 3 days on any changes the patient had made, and I also assisted my clinical instructor in discharge equipment needs and was involved with caregiver education. So the results from therapy. This patient was actually very successful with physical therapy. They were able to reach most of their goals. So the initial challenge that we faced was strengthening. So we had to really focus on bed mobility with this patient so that they could progress to become ambulatory. Another challenge that we faced was when it came to gait training was that this patient had a lot of difficulty with left heel strike. So something that my clinical instructor showed me was by adding a 2-pound ankle weight to their left ankle, it could help facilitate heel strike while ambulating, and that was something that we were successful with. So upon discharge, the patient was able to ambulate 50 feet with contact guard using a quad cane on the right side. They required supervision with wheelchair management and bed mobility, and contact guard with sit-to-stand transfers. So the patient was unable to meet their stair or curb goals, but the patient was going to continue to work on that with home health. So discharge plans. The patient was discharged home with caregiver and home health to continue physical therapy. The patient was discharged with a wheelchair and quad cane for home use, and one main objective for home health was to become more confident in stair climbing and continue to strengthen the left lower extremity muscles for gait. So family education. So here at the inpatient rehab, periodically we would have the family come to participate in family training, where we would just kind of show them how the patient was progressing, and also give some education to the family as well, answer any questions they might have, make sure that they were comfortable when the patient was discharged. So I, was able to kind of take charge of that, which was a good learning experience. So the appropriateness of physical therapy. So I felt that the therapy the patient received was very appropriate for their level of ability as well as their diagnosis. I think that what we had the patient doing was acceptable, was at an acceptable level, but it didn't push them to become unsafe with any of their treatment. And I think that the patient did really well overall with their physical therapy and were able to meet most of their goals. So what did I learn? So I learned a few things. I learned a lot about functional training with a stroke patient. I learned a lot about functional mobility and gait training with a stroke patient. Like I said earlier, I had never seen using a cuff weight on the ankle to help facilitate heel strike, but this was something that was really effective and really helped this patient. I also learned a lot about neuro re-education. We did a lot of just exercises in front of the mirror, just so that the patient could have some symmetry training, be able to see themselves in the mirror, because they were having some hemi-neglect and things like that. So that was something that was really helpful. And then too, I learned when it came to using the mirror, we drew with a dry erase marker just a straight line down the mirror, and was able to give the patient kind of like a midline point. Something that they were able to kind of to judge if they were getting off balance, getting out of their midline, and again, that was something that was really helpful for the patient. So overall, I learned a lot about neuro patients, and I feel a lot more comfortable and confident in my abilities to work with stroke and neuro disorders after completing this case study. Thank you.